Hello everyone. Welcome to Chapter 10. Today we'll be discussing pages 443 to 463 in your text about important medications in the pre-hospital setting. One of the things that I want to make sure you understand is that this lecture is not a comprehensive lecture on learning these medications. It's more of an orientation to body systems and the medications that may be provided by the paramedic or that the paramedic may run into in a patient's medication list, and the fact that those particular medications correspond to affecting a particular body system. There'll be a lot more on emergency medications later on this semester, and you can see that on your schedule by the individual medications that are listed out. And again, we'll do that by body system as well, but we'll get into much more detail. This is your introduction to the medications. Now, in your text, right off the bat, they give you a large table. It's table 12, goes through quite a few pages. And I find that I could think that if I were in your shoes, I'd find this chart a little bit daunting. So here's what I've done. I'm going to fade away the classes of medications that, while we need to have at least some background in, we don't necessarily need to know in great detail. So on this particular chart, everything that just became faded into the background are drugs that, again, or classes of drugs that we won't be giving directly as paramedics. Not too much of a call for emergency antacids or emergency antidiarrheals. Now, I've provided antidiarrheals in my practice when I worked in occupational health. That was one of the medications that I could provide according to my protocols. But it was an oral medication. It wasn't a medication that immediately took effect. In fact, it's listed here on the right as Imodium. That's the brand name. And again, I'm not quite as averse to describing medications by their brand names, because that's what you're going to see out on the drugstore shelf. And again, that's not really an emergency medication. Same goes with antacids. I could give antacids in my occupational days as well. Didn't want folks to go home just because they had a little heartburn after lunch. But on this table, agents that we will discuss in this lecture include I never have been good at this one. Alkalizing agents. And the one that we speak of is sodium bicarbonate. What's interesting is that drug's primary use in emergency care has pretty much faded away over the last 20 years or so. We will talk about antidysrhythmics, and we'll actually get into a bit of detail about those because there are various classes within the medication class, and each one of them performs a different function. Antiemetics are used to treat nausea and vomiting. And we do have those on our formularies, Phenergan and Zofran. And finally here on this chart, antihistamines. And the primary one used in emergency care is Benadryl. And we'll talk a little bit about that today. Next part of Table 12 is pretty large, but again, thankfully, not all of these medication classes are ones that we need to know in a great deal of detail. Here are the ones that we do actually need to address in emergency pharmacology. If we go back up to, say, antipsychotics, which is the third one down here, Haldol. Haldol is in your text, but I was unable to find it in any local, state, or national protocol book. And when I say national protocol book, I mean the formulary that's on the National EMS Education Standards, which are the drugs that will be available to you when you take your national registry examination. So we shouldn't expect to see Haldol. And that's an antipsychotic, but there are some systems that might use that as an emergency medication, but not around here. So we have the benzodiazepines, which include Ativan, Valium. Certainly, folks need to be familiar with those. Those are given in most all the systems around here. Beta agonists, which is albuterol. So your inhaled albuterol is in that class. Metoprolol or Lopressor is on the state protocol book, as I recall. Once we get to that slide, we'll see that. And then calcium channel blockers, the big one being Ditalizem or Cardizem, is definitely a pre-hospital care drug. Now, other drugs that you've heard of, certainly, is another one here, the cardiac glycoside called digoxin. We've already talked about that's my primary example of one that comes from a plant-based source. Much more use of digoxin in chronic care. In fact, it's not used in emergency care, at least that I can find, directly. So you're not going to be pushing an IV dose of digoxin into a person. What's interesting is my wife, moving back from Minnesota, is surprised to see how much digoxin is used here in Kentucky, because in Minnesota its use has kind of faded away. Now, one of the drugs classes here that everyone kind of hears of, because lots of people are on them, but we're not going to give them in the emergency arena, are cholesterol synthesis inhibitors. They're the third one down in the second fade box or shaded box. And those are the drugs that everybody calls the statins. Lipitor, Zocor are the ones that are being used as examples here. Lots of folks on them. It affects the gastrointestinal system by preventing cholesterol conversion in the liver, but it's given to people who have hyperlipidemia to hopefully decrease the amount of cholesterol in the blood, especially for folks who are at risk of having blockages in their coronary arteries. So while it's a gastrointestinal medication, in reality, for paramedics, we should think of it more as being a drug that indicates that a patient has some sort of cardiac history. Next on the list of drugs that we might actually need to know fairly well include corticosteroids. Dexamethasone is on the Kentucky formulary. Again, we'll get into a lot more detail later on. Right now, it's just important to know that it is a drug that here in the Commonwealth, is being used. Cough suppressants, digestants, obviously those are not things that we're going to be too concerned with for us. In my occupational setting, I did give dextromethorphan as a cough suppressant. I had orders for that. Diuretics and fibrinolytics certainly are ones that we'll go into in a bit more detail. Both mannitol and furosemide are on the formularies of the Kentucky state protocols. And if I recall correctly, furosemide is not on the national formulary, and neither is mannitol, but they're both on Kentucky. Fibrinolytics include TPA. Again, those are not on either one of the national or state lists, but we're going to go over those in detail because there's a chance that you might see those out in the field, especially in transfer situations where you're taking a patient who may have had a fibrinolytic administered them in an outlying hospital, and now they're being sent to a specialty hospital, usually in an urban center. One more on this chart to at least be familiar with is the histamine 2 receptor antagonist. It's the second box from the bottom. That includes Pepcid and Zantac. A lot of folks are being prescribed this prophylactically. In other words, they don't have any particular sign or symptom of what is treated by the drug, but they have some other condition where this medication may inhibit the the formation of signs and symptoms or the initiation of signs and symptoms. This is especially given to some folks who are on chronic aspirin therapy or taking 82 milligrams of aspirin a day. They'll be given Pepcid or Zantac to help protect their stomachs from the buildup of acid from the aspirin. Finally, our last shot at table 12, another large table here. Again, not a lot of them on here that we need to know in emergency pharmacology, but again, we should be at least a little bit familiar with. Because again, you heard me say it before, when I'd walk into a home to do an initial contact with a patient, if I was riding with an emergency medical technician, the EMT would perform the primary survey and get the vital signs on the patient. So they made the true initial contact. I would say hello, but then I would want to see the patient's medication list or their bottles, because I tended to have more of a background in what those medications might mean for the patient's history. Now, the EMT took the history, asked what kind of medical history do you have, but then if I saw a medication that didn't lend itself to the history that the EMT obtained, I would know to ask the question. Hey, you're taking medication X. Could you tell me what you're taking that for? Would be the question that I would ask. And sometimes that would elicit a better history. So on this chart, these are the only ones, again, that we'll need to know in any great detail. It includes insulin. Insulin is on, I'm looking it up as I'm reading, is on Kentucky's formulary, so we're going to make sure that you know that fairly well. Again, it's not on the National Education Standards formulary. I've never administered insulin, and when I was a paramedic student, insulin had to be administered by at least 2 registered nurses simultaneously. One had to check the other. Narcotic analgesics include morphine and hydrocodone. Obviously, morphine is in one that we give. Fentanyl is also a narcotic analgesic that's making something of inroads around here. Non-steroidal anti-inflammatory drugs include Toradol. That is a drug that might be given by injection. The rest of these, for the most part, the indomethacin, I'm not aware of that being an over-the-counter, but obviously ibuprofen is. Oral contraceptives, the next shaded box down. We do need to have at least a little bit of a background on oral contraceptives because they have side effects and adverse effects that are pretty serious and are emergencies. I once responded to a woman who was 23 years old who was having a stroke. And that doesn't make a lot of sense for a healthy 23-year-old. But then when we found out that she was on oral contraceptives, that clicks. And not that we didn't believe she was having a stroke. She was showing all the signs and symptoms. But once we found out that she was on oral contraceptives, we were led to, we were able to come to the conclusion that that might be one of the precipitating factors in her having her stroke. Oral hypoglycemic agents. You may think, well, wait a second, that might be something we need to administer. No, it's not. We don't really manage hyperglycemia. If we do, we're going to manage it potentially with insulin. And so these are drugs here in the oral hypoglycemics that you just need to have you need to clue in. These are the kinds of medications that if the person doesn't give you a good history, you're going to know that they're a type 2 diabetic, that they suffer from hyperglycemia. Metformin, glipizide, diabeta. Those are all medications that should key you into the fact that your patient has type 2 diabetes. The erectile dysfunction medications, again, you can try to pronounce that word over there. But Viagra, Cialis, we just know that we can give nitroglycerin, which can have an extraordinary potentiating effect on that medication and may cause a problem with hypotension. Platelet inhibitors, folks think of aspirin now as being more of a heart attack medication even than an analgesic. Aspirin is a non-steroidal anti-inflammatory. It's just that it's become more prevalent in its administration as a antiplatelet drug. And even that now is beginning to come into some question in the science. So I think we're going to be watching that as we go through paramedic school together to see how that's going to go on as far as whether or not chronic aspirin therapy is going to continue to be a thing. Protein pump inhibitors is another drug that's being given to lots of folks on multiple medications that suppresses acid secretion in the stomach. Then finally, the sympathomimetics and the tocolytics are both drugs that we might see. Obviously, here is epinephrine, and that's one of obviously we give in the field. And then magnesium sulfate can be given to both patients in particular kinds of cardiac arrhythmia or dysrhythmia, and then also to eliminate uterine contractions in preterm labor. So there'll be different uses. Again, we're not going to get into the extraordinarily detailed use of each type of medication in this lecture today. All right, so let's get into some particular medications. Again, just doing a quick overview orientation. The first one from the slides that come from your textbook's publisher is already kind of out of date, and that is the use of ketamine for a sedative and or hypnotic effect when you need to manage the airway of a patient. It really isn't used for this anymore. It's found to have side effects that are a bit too profound, but it is being used quite effectively for excited delirium, and that's going to be a hot button phrase. I first really heard about it in Minneapolis about 4 or 5, well, now probably more like 6 or 7 years ago. And the use of ketamine intramuscular injection has had a profound effect on the treatment of patients demonstrating excited delirium, and we'll get more into that later on. Next, we're gonna skip. If you read your chapter, and you should have, you'll see that there were a lot more medications used in airway management in the chapter than I'm going to go over here in the slides. And the primary reason is that none of the ones that they put in there, the paralytics and medications in those classifications, none of them appear on either the Commonwealth of Kentucky nor the National Education Standard formularies. Neither one of them do. So while you still should read your chapter and you will be held responsible for information in the book, I'm not going to go over them here in lecture. Next, we're going to talk about medications used in respiratory management. And the first ones of these are the beta agonists. These are primarily used for the treatment of bronchospasm. And what they do is they cause bronchodilation through smooth muscle relaxation. All right, so our beta agonists, albuterol, pretty much the one that we see in the field. We can both give this in a nebulized state that we carry with us, or you may see patients with a metered dose inhaler. And this is a rescue inhaler, obviously. Other medications that are given sometimes include terbutaline, not something that we see in the pre-hospital field all that often. The other one is epinephrine, including racemic epinephrine for asthma or for bronchoconstriction. Not seen that often anymore. We did have it where I was in Minnesota. The St. Paul, the East Metro system of the Twin Cities, did have racemic epinephrine, whereas the West Metro did not. Next are the mucokinetic and bronchodilator medications. The primary one that you may see in the field is Atrovent, and Atrovent is sometimes combined with albuterol, forming a drug that is commercially known as Combivent. Atrovent is given in cases where you hear not only wheezing but also wet breath sounds, as Atrovent is basically inhaled atropine. Finally, there are the corticosteroids. Now, these are the drugs that you see advertised on television to reduce the incidence of asthma attacks. Really not given by pre-hospital care providers because they are administered to reduce airway inflammation over time, whereas we're more concerned with once an attack begins to decrease airway inflammation immediately. Couple of problems with corticosteroids is that with long-term administration, they can have an immunosuppressant effect, as all steroids do. And they also have many contraindications and adverse effects. And this is another reason why you're just not going to see these in your paramedic med box. All right, turning from respiratory management to the cardiovascular system, we've said in lectures in intro that if EMTs were a product of trauma, that paramedics were a product of heart attacks. This is kind of the epicenter of pharmacology for paramedics, so we'll have quite a bit of stuff related to medications affecting the cardiovascular system. The first type are antidysrhythmic medications. These, in various different ways, target cells within the heart to either resolve dysrhythmias or to suppress ectopic foci. And ectopic foci cause extra or out of rhythm beats in the heart that then can become dangerous. The Vaughan Williams classification group system classes these into 4 different areas. We're going to talk about those 4 different areas in just a moment, but basically there are 4 different types of antiarrhythmic medications because they tend to have an effect on one of the 4 active phases of the cardiac cell activity in each contraction of the heart. There are 4 active phases, and then there's another phase called phase 4 is the inactive phase, but there are 4 active phases, 0, 1, 2, and 3. And this is graphically described in your book on page 450. So you should turn to page 450 of your book to see what each one of these represent. Just know this for now. Phase 0, which is the rapid influx of sodium ions into myocardial cells, is what causes the heart to beat. And if you think about it, the heart, and we're talking about the ventricles here, to actually push blood out into the body. We'll talk about how this particular chart lines up with EKG later on. And the big complex that you see on an EKG called a QRS complex lines up more or less with phase 0. So the first class in the Vaughan Williams classification system is a class 1 antidysrhythmic. And what it does is it slows the movement of the sodium in the cardiac cells. Examples include procainamide and lidocaine. Lidocaine also, you may have heard of that perhaps in the emergency room or other places, is also an anesthetic that is used to numb an area before suturing, but this is a different concentration of the drug. Again, just know that procainamide and lidocaine are class 1 antidysrhythmics, and that these slow the movement of sodium in cardiac cells. Make sure you're reading your textbook for more details. Class 2 are beta-adrenergic blocking agents. Remember, adrenergic cells are part of the autonomic nervous system. And what this does is that it inhibits the activation of catecholamine to the beta receptor sites. Now, the interesting part about this is that when given, it may cause massive conduction abnormalities when they're given with calcium channel blockers. So some, well, the one example that we have available in Kentucky at least is metoprolol, also known as Lopressor. Now, quite frankly, a lot of folks out in the world who have high blood pressure are on metoprolol every day. And what it does is it reduces the heart rate. And if you can reduce the heart rate, you're reducing the amount of work that the myocardium, the heart muscle, is having to do. So in the presence of ischemia, which is a lack of oxygen to the myocardial cells, reducing the heart rate reduces the amount of oxygen that those myocardial cells need to do what they need to do to function. So what it does is it reduces oxygen demand, which is a good thing when the oxygen supply is for some reason lowered to an unhealthy level. It can also be used in atrial tachycardias, and right now you don't need to know that in detail. Again, make sure you're reading your book. Here in Kentucky, metoprolol is on the formulary for the treatment of acute hypertension, a person who has a sudden spike in their blood pressure. Next are class 3 antidysrhythmics. These prolong the period in which the heart cannot accept any other signals, electrical signals, to go back through phase 0, 1, 2, 3, 4. It prolongs the absolute period where, when resting, the myocardial cell cannot take on another signal to contract. And so the nice thing about this is when I became a paramedic, we really didn't have a class 3 antidysrhythmic that we could use. So we had to be very careful about the antidysrhythmics that we used in atrial versus ventricular tachycardias. And when amiodarone, the drug here, came along, it was a real, it really did open things up for us, because amiodarone really won't hurt a person who doesn't have an atrial tachycardia versus a ventricular, or a ventricular versus atrial. It's much safer. So we still have to be careful. But at the same time, we have a drug that can treat either one at the same time. Now, we paramedics in the pre-hospital setting always administer this via IV, either through an IV bolus, such as in cardiac arrest, or through an IV drip, such as when you have a patient with a fast heartbeat called supraventricular tachycardia. And again, you don't have to get wound up in those things right now. We'll get to those later. Oral administration is chronic. So a doctor prescribes it, and the patient can be on this medication for years at a time. But that really isn't something that we will do, obviously. Now, it can cause adverse cardiovascular effects and some pulmonary conditions, but in the emergency setting, we want to resolve the dysrhythmia. So those generally aren't taken into consideration if our protocols say that we should be providing this medication. Next is class 4. Class 4 are called calcium channel blockers, and the primary example that is more popular in the field today is called ditalazem or cardizem, and we'll see that on the next slide. There are a variety of potential uses. Supraventricular tachycardia is the primary one. Do at least know that it's a calcium channel blocker. Unfortunately, we're kind of showing you things that you really haven't had a background with yet. Automaticity is the capability of cardiac cells to create their own signals, to be their own conductor, basically. We'll get to more of that later on, but basically what happens here is that calcium channel blockers slow the process down, is what it comes down to. The two drugs that are mentioned in your text are verapamil and ditalazem, and both of them control the heart rate in patients with either atrial fib or atrial flutter. You'll see quite a number of patients on either one of these medications chronically. So in other words, you'll see pill bottles with prescriptions for one of these two drugs. I don't know if you would see both. That would be something to look up. For us in the field, we provide it pretty quickly, administer it IV over about 2 minutes, and that's fairly fast. But at the same time, we have to make sure that we have EKG running all the time and that we're checking their blood pressure often. This can cause profound drops in blood pressure if it's given too quickly or if you overdose the patient. So very important that we don't do that, obviously. Finally, we have a drug that's in an unnamed class, and that's adenosine, brand name Adenocard. This decreases cardiac conduction velocity. It literally slows the signals throughout the heart. It produces a pause in cardiac activity. The first time that I provided this to a patient, the patient went into asystole or flatline on the cardiac monitor for about 5 or 6 seconds, as I recall, and then went through a whole bunch of different dysrhythmias until they went back to where they were. This is primarily given to supraventricular tachycardias in patients who are not unstable enough to be cardioverted. Again, I know that's all stuff that you don't necessarily know right now, but cardioversion is the application of electrical dosages through a defibrillator or a cardioverter. The thing about adenosine is it has an extraordinarily short half-life, and we've described that in class. It has a rapid onset and a very brief duration. We want to administer it through a large bore proximal IV, and when it says proximal IV, this would be the one time when we want to start that 18 gauge, maybe 16 gauge angiocath in that anacubital fossa, and I apologize for the mispronunciation, but in that AC right there in that elbow, to make sure that we get this to where it needs to be before it gets metabolized, quite frankly. We keep going down here. We have alpha adrenergic receptor antagonists. These prevent endogenous catecholamines from reaching beta alpha receptors. They tend to lower blood pressure, decrease systemic vascular resistance. In other words, the vessels become less resistant. They dilate. These are generally prescribed for patients with hypertension and a large prostate or glaucoma. Again, we're not going to be providing these in pre-hospital care. Clonidine is one that I've seen quite a bit. Again, we want to make sure that you understand that if you saw clonidine on a person's medication list, that you understand that they have some sort of cardiovascular problem to which they're trying to antagonize the alpha adrenergic receptors. So again, it's not that you'll be giving it, it's that you should be able to recognize it. Another one that I've seen this, for me, phentolamine is not one that I can remember seeing all that often, but labetalol is one that I did see every once in a while. Again, just a different way for it to a different medication that controls hypertension. Another one is the angiotensin converting enzyme inhibitors. These alter the function of the renin-angiotensin system, and this can cause blood pressure and cardiac afterload to decrease. One of the things about these drugs is that a common side effect is that the patient will have a chronic dry cough. Also, some patients can have a sudden life-threatening angioedema, and that's swelling of the face and neck. There are quite a few articles and EMS articles out there about angioedema in the presence of a drug called lisinopril, which has become very popular of late for blood pressure control, especially in combination with drugs that affect heart rate, such as beta blockers. Another cardiovascular medication include the anticholinergic medications, such as atropine. Atropine is its effectiveness is related to its concentration at the receptor sites compared with acetylcholine. So in other words, it competes for those sites. We use it in pre-hospital care primarily to treat bradycardia when we think that there may be vagal stimulation. These cases are usually where the EKG looks fairly normal, but the heart rate is extremely slow. Atropine is used to try to speed up heart rate. So this is slow heart rate, give atropine situation. We haven't really, and I've kind of skipped over all the paralytics for airway management. Again, you should read those in your book. There are some airway management drugs, the paralytics that can cause problems that atropine can address. You can read about those in your book. And also another thing that we use atropine for is it can be a life-saving antidote for acetylcholinesterase inhibitor toxicity. And here I mentioned in at least one of the classrooms Sevin, which is a powder form insecticide for aphids. And it's an extraordinary, what's called an organophosphate. And large doses of atropine need to be given to people who show signs and symptoms of organophosphate poisoning, and that's what this is showing here. Also in the military realm, atropine is considered the antidote, the quick-acting antidote for nerve agent exposure. Nerve agents have a very similar, they're in the same family as Sevin, the organophosphates.